The broadcast is now starting. All attendees are in listen-only mode.
Welcome. I think everybody's on here. Good evening. This is Catherine Poole. I'm the president and founder of the Melanoma International Foundation. Let me apologize for our lateness. Technology is wonderful when it works, and when it doesn't work, it's very frustrating. But welcome to our webinar. Melanoma has always been considered a very immune-responsive disease. The therapies we are discussing tonight are designed to manipulate the immune system to eliminate melanoma. Many of you I know are trying these therapies, and others are contemplating them. We thank you for trying these new agents because without your involvement, research really can't go forward. So thank you so much. It's now my pleasure to introduce the MIF Scientific Advisory Board member, Jedd Wolchock. He is one of the best experts we know on immunotherapy. He is the Director of Immunotherapy Clinical Trials at Memorial Sloan Kettering Cancer Center. Dr. Wolchock is most generous to share his time with us tonight. So now I will turn it over to Jedd to show his slides and tell us all about this. Thank you.
Well, thank you very much, Catherine. And also, I'd really like to thank all the attendees for taking time out of their day to attend this webinar as well. And to second Catherine's words about the importance of participating in clinical trials, that it really is extremely important, and we are very grateful for everyone's contributions to research programs like this. Okay, I'm just going to now figure out how to advance the slides. Okay.
Jedd, just go ahead and use your right and left arrow keys.
Oh, okay. Not working. Okay. So my big messages for the webinar are that this is really a time of very great hope in the battle against melanoma. That not only because of the advances in immunotherapy, but because of the advances in targeted pathway inhibitors such as the RAF inhibitors and KIT inhibitors that you may have heard previous webinars about. This is really a time of unprecedented progress in the battle to control melanoma. So I think that that's a very important message to keep in mind. And also, I would like to wave the flag in support of grassroots efforts like Catherine's to support patient education and encourage clinical research. In addition, I'd like to acknowledge the fact that there are very many institutions around the country who are conducting cutting-edge clinical trials, and again, the importance of participating in them. So I wanted to review a little bit the history of immunotherapy, and I think it's always important to recognize where the field may have started. And this field actually traces its roots to actually the folks in that photograph there, and the dapper young gentleman with the bowler hat in his hand is John D. Rockefeller Jr. at about age 17. And the young woman next to him was his friend Bessie Dashiell, who died about 1 year after this picture was taken from a sarcoma on her arm. And this sarcoma was removed by the most outstanding surgeon in the New York area at the time, whose name was William Coley. And Coley is the middle gentleman with his arms crossed in this next picture, who was quite emotionally taken aback by the death of this young woman from cancer. And the death of this young woman also obviously had an impact on the Rockefeller family, who decided to commit significant portions of their family fortune to medical research. But it was in fact Coley who began to think about how we could treat cancer other than removing it surgically, which was the only thing known at the time in the late 1800s. And you can see actually at the bottom of this photograph, it says R&C Hospital Christmas Party 1892. And the R&C Hospital stands for the Hospital of the Ruptured and the Crippled, which we now more politically correctly call the Hospital for Special Surgery here in New York. But Coley actually made an observation at the time that any of his patients who had infections after surgery seemed to do better than those patients who didn't have infections after surgery for cancer. And since little to nothing was known about the immune system at that time, it was quite insightful for Coley to come up with the idea that it was some sort of stimulation of the immune system by the infections that patients had. And remember, surgery in the late 1800s, very different than surgery today. No antibiotics, no sterile technique, no disposable sterile gloves. So infections were more common. But he really theorized that infections stimulated the immune system, and the immune system was responsible for these patients doing better in terms of their cancer being under control. It took almost 100 years for us to prove that, in fact, Coley was right. But, in fact, we now believe that he really was. And in the next picture is just the medical data from the time, which is a gentleman who had a sarcoma on the neck, which was injected with bacteria to intentionally give the patient an infection. And the patient actually did well for 7 years when this photograph was taken. So the challenge that we have really as cancer immunologists is that to the immune system, cancers look very much like the normal cells that they came from. So if it's a melanoma, the immune system doesn't necessarily see that melanoma as being much different than the normal skin melanocyte that it came from. And the challenge that we have really is to get the immune system to recognize something that for all the world looks like our own body. We know that the immune system doesn't like to recognize our own bodies because otherwise we end up with autoimmune disease. And so it is not an easy job. And in fact, it's taken almost 100 years for us to figure out ways to get the immune system to recognize cancers as being a legitimate target. Just to review with everyone, there are 3 drugs approved for the treatment of melanoma in the U.S. right now: dacarbazine and high-dose IL-2 for metastatic melanoma, and interferon alpha for treatment in the adjuvant setting after surgery. And it's probably not a big coincidence that 2 of those 3 medications are, in fact, immunotherapies. But it's also very clear from the shortness of that list that we need new drugs approved for melanoma. And I would predict that by this time next year, we should very well have at least 2 more drugs added to that list, which is certainly, again, a source of great hope and inspiration. Just to review a little bit of the ongoing standard immunotherapies, as you know, interleukin-2 was approved about 12 years ago, and it was, I think, the first example of how the immune system can be used to treat cancer, because interleukin-2 doesn't do anything to melanoma itself. Interleukin-2 is a growth factor for T cells, which are immune cells that go out and then treat the cancer. So the fact that even a few people get better from high-dose IL-2 is very strong evidence that the immune system, when properly trained, can conquer cancer. This is the data that led to IL-2 being approved. This is what's called a survival curve. And up on the right side, you can see the response rate, the number of people whose melanoma got smaller by at least 50%, was only 16% of people treated. And so that's one of the challenges with IL-2, is that not very many people benefit. What got the drug approved is the flatness of that blue line after 2 years. So what that blue line represents is that if you have a complete response to high-dose IL-2 and you're still without recurrence after 2 years, then there is a very, very high chance that you will not have another recurrence for over 10 years. And so it's the durability of the responses, small as they may be, to high-dose IL-2 that was responsible for it being approved, and for the fact that it's still being used today. We all know that high-dose IL-2 has some side effects which can limit its use in some people who cannot tolerate it, but it is useful in a small number of people because it does cause these durable complete remissions. Now, I'm going to briefly introduce you to the idea of another kind of immune therapy, that which blocks a marker called CTLA4. And I'm going to go through this intentionally kind of slowly so that everybody understands how it works. On the left side of the slide, on the top, the blue cell is a resting T cell. And the way that T cells work is that they recognize a target called an antigen with the TCR, or the T cell receptor. That's sort of the lock and the key of the T cell finding its target on a cancer cell. Just to the right of that is another pair of molecules called CD28 and B7. And they also need to find each other in order for the T cell to become activated. So there are two signals, the T cell receptor finding its target and this CD28 marker and the B7 marker finding each other. Those two things need to happen, and then the T cell becomes activated. Once the T cell becomes activated, then another marker called CTLA4, which usually sits inside the cell, you can see it as an orange fork on the left. Once the T cell becomes activated, that CTLA4 molecule travels through the cell into that space between the T cell and the cancer cell, or the antigen-presenting cell. And CTLA4's purpose is to start to turn off the immune system. Now, why would it be necessary to turn off the immune system once it's been activated? Doesn't the immune system just do good things? Well, no. We know that the immune system, when it's overactivated, can cause diseases like autoimmune disease. And so as a way to protect the immune system from getting overactivated or even exhausting itself, and therefore not having a good immune response, CTLA4 begins to turn off the immune response once it's been started. So it's sort of a braking mechanism to try to slow things down so they don't get out of control. Now, Ipilimumab, which is a drug that is in the latest stages of clinical trials, right now, the phase 3 data, which I'm going to go through, has shown that it has an effect on melanoma. Ipilimumab is an antibody that blocks CTLA4. So it keeps this brake from slowing down the T cell and therefore allows the T cells to become more activated than they otherwise would. The simpler way to think about this is that getting your immune system started is just like starting your car. The very specific interaction between the T cell receptor and the target on the cancer cell is like putting in the ignition key and turning it. But that's not enough to get the car moving. In order to get the car moving, you also have to step on the gas. And that's that signal 2 between CD28 and B7. We all know what happens if you have a car that has a gas but no brake. That car will continue to accelerate and could crash, and that's really what happens if you don't have CTLA4. So CTLA4 is like the brake on T cells, and what we're seeking to do with Ipilimumab is to temporarily cut the brakes. We know that permanently cutting the brakes would be a very bad thing because there are some animals and even some people who have inborn errors in CTLA4, and they develop very bad autoimmune disease. So we know it's important not to turn off CTLA4 forever, but my colleague, Dr. Jim Allison, who was the person who invented Ipilimumab, came up with the idea of temporarily blocking it with this antibody, Ipilimumab, as a way to get the immune system to see cancer better. So I'm going to review with you the data that was presented at ASCO, the American Society for Clinical Oncology meeting, and then published in the New England Journal of Medicine this past summer. And this was a study called MDX-010-20, and it was called MDX-010 because before Ipilimumab had that name, it was called MDX-010. And I should also say that now that Ipilimumab is very close to a final decision from the FDA, it does have a trade name which is called Yervoy, Y-E-R-V-O-Y. But I'm still not very used to using that word, and I like Ipilimumab, or Ipi, better, so that's how I'm going to refer to it. This was a study that was for patients with previously treated stage 3 or 4 melanoma. It accrued patients for almost 4 years, between 2004 and 2008, at 125 centers in 13 countries. It was a phase 3 double-blind randomized trial in which some people got Ipilimumab alone, some people got Ipilimumab along with an experimental vaccine, and some people got the vaccine alone. It was not thought that very many people would benefit from the vaccine alone, and so that could be considered sort of the control group. And you can see that there were 400 people who got the combination and about 130 to 140 who got either Ipi alone or the vaccine alone. And this was blinded to both the patients and the doctors. The main objective of the study was to see which group lived longer. And the way that the doses were given were the Ipi was 3 milligrams per kilogram, which is sort of a middle range dose, every 3 weeks by IV for 4 doses. The GP100 vaccine was given as a shot under the skin on the same days that the patients got Ipi. And if there were people who had a benefit, and after some time that benefit went away and they had a relapse, patients were allowed to get the same treatment that they were originally assigned to again. These were the eligibility criteria. I think we reviewed most of this. People had to be HLA-A2 positive because the vaccine was only theorized to work in HLA-A2 positive people. People could have had brain mets, but they needed to be previously treated. And nobody could have autoimmune disease. This is sort of a picture of the way that the study ran. And I think we went through most of this already. This was the important data from this clinical trial. And these are the survival curves, how long people lived in the different groups. And what you can see is that the green and the blue groups, which are the 2 groups that had Ipi, lived significantly longer than the group of patients that only got GP100 alone. And there was no significant difference in the 2 Ipi groups. So it didn't really matter whether or not people got vaccine. How long they lived was determined just by whether or not they got Ipi or not. And importantly, the overall survival improved from an average of 6 months to 10 months for the 2 Ipi groups. And the number of people alive at 1 year and 2 years doubled in the Ipi groups compared to the group that got the GP100 vaccine alone. Now, that was the most important endpoint, which is the how long people live. But if we look at something called the best objective response rate, or how much smaller tumors got on scans, we actually see in the top row there that the Ipi alone group had about 11% of people who had their tumors get smaller by at least 50%, measured at one point in time at week 12. The GP100 group, about 1.5% of people, but the Ipi plus GP100 group actually, by this measure, did not do as well as Ipi alone, and we're still trying to figure out why. We don't think it's really that important because in the end, those people live just as long as the people who got Ipi alone. So when tumors shrink on a scan may not be important when the overall endpoint is really survival. Now, there are side effects from from Ipi, and they have to do with inflammation occurring in different parts of the body. The two most common places for side effects to occur are on the skin, where itching or a very faint rash are the most common findings. More serious skin rashes have been seen, but they're very rare. And most of the skin problems can be taken care of just with creams or sometimes some antihistamines like Benadryl are needed. The most concerning side effects are in the gastrointestinal tract, and they can range from diarrhea up to inflammation of the intestines or colitis. And if the diarrhea is not treated early, then it can progress to colitis. And in fact, a few people died from colitis at the very beginning of the clinical trial program. Now that we, the investigators and doctors, know, after treating several thousand patients, that that is a side effect to be concerned with, the likelihood of someone dying or getting very serious colitis is extremely small. Again, it's all based on good communication between patients and their caregivers, so that these side effects are picked up early because they're very, very treatable with pills like prednisone. There are other side effects which can affect some glands in the body, like the thyroid or the pituitary gland, which similarly can be treated with hormones. And there can be elevation of liver function tests, which also are treated with steroids. Again, early recognition of the symptoms is very important in reversing them. Okay. In the next slide is just showing what happens to the people who had a benefit, had their disease go under control, but then have a recurrence. And what you can see is that even though the numbers are really small, and the numbers are small because, truthfully, the number of people who have a recurrence after having benefit from Ipi is very small. Most people who have a benefit keep that benefit for several years. So you can see that there are some people who have to have what's called re-induction or repeat treatment, and there are some of those people who can go back into disease control. And in the next slide, this breaks it down by what people's response was to the first set of treatments, the induction, and then what happened after the re-induction, after they had a recurrence and then were retreated. And you can see that some people who had a partial response went back into partial response, or even then had a complete response when they were treated the second time. Some people who had stable disease ended up doing even better and having a partial response when they relapsed. But the important take-home message here is that even if you have a recurrence after showing benefit from Ipi, you can go back into disease control again if you're treated again. So this is just a source of great pride and hope. These are the two babies of one of my patients from the MDX-01020 study who were born after she had a complete remission from metastatic melanoma in the brain, chest, and adrenal gland. And despite all of our fear about what a pregnancy would be like after Ipilimumab, you can see that those couldn't be two more beautiful children. And so this is one of those things that gives us hope every day. Now, as I said before, sometimes these tumors will not shrink at a planned point in time. Sometimes these tumors will actually grow and then shrink. And this is a picture of a CAT scan of one of my patients, and the big kind of gray organ in the upper left-hand side is the patient's liver. And there are some small, darker gray dots there. This patient was treated over 4 years ago, and at week 12, which was the first set of CAT scans after the 4 doses of Ipi, you can see that that liver looks worse. There are new spots. The ones that were there are bigger. However, the patient said to me on that day, I feel better. My night sweats have gone away. My fevers have gone away. My liver doesn't hurt me as much this week as it did last week. So I listened to the patient, and I did absolutely nothing. Didn't go on to another treatment because I said, you know, with Ipi, we're treating the patient and not the tumor. The Ipi works by activating the immune system, and then the immune system has to go out and treat the tumors. And we don't know when that happens. We don't know if that's going to happen at week 10, week 12, week 14, week 16. So I'm going to give this a little bit more time. And so we gave it some more time, and you can see what happened. The disease started to go away. And I can tell you, I just called this patient over the weekend, and 4 years after these scans were done, gave him a birthday present of the fact that he is still in a complete remission. But if we had believed those scans at week 12, we would say the drug doesn't work. So we have to have a very open mind with drugs like Ipilimumab that don't treat the tumor directly. We've seen from Dr. Flaherty and others that drugs that treat the tumor directly, like the BRAF inhibitors, when they work fast. You know, within a few weeks, you can see the tumors going away because that is directly treating the tumor, attacking the BRAF inside the tumor. This is treating the person and asking the person's immune system to go out and treat the tumor. And that may happen soon or that may happen later. And this just shows you a little bit more about what happened with the liver in this patient. Okay. Oh, let me just go back. So I just want to give you a little bit of an introduction to what the numbers are like, to how many people have these very delayed responses. So this is a chart of all the people that were in the phase 2 clinical trials of Ipi. And there were 227 people, and we're just going to concentrate on the left side of this chart. There were 123 people who had PD, or progressive disease, by scans at week 12. Of that 123 people, 57, or almost half, were followed beyond that with no additional treatment for their melanoma, just like my patient with the liver problem. Just scans, no additional treatment. Of that 57 people, 14, or about a fourth of them, had delayed benefit. So we believe that somewhere between 10 and 25% of people whose scans get worse at week 12 will eventually get better. And what you can see is in the next chart is that the survival curves of these people with delayed responses, which are on the dark blue line there, those patients do just as well as the people whose tumors shrink on schedule at the very beginning, which is that turquoise line on top. So based on this, myself and colleagues from the Ipilimumab program, both doctors in the community as well as our colleagues at Bristol Myers Squibb, have developed a new set of rules by which to judge response to immunotherapies called the immune-related response criteria. And we are now trying to validate these in studies going forward to open everyone's mind that responses to immunotherapy may not happen on schedule. So we went through what the side effects were, and this just breaks down what our experience at Sloan Kettering has been in terms of the percentages across all of the studies that we've conducted here. And the important part is really on the bottom there in red. The severity of the side effects is inversely related to the vigilance of surveillance, meaning the more talking that goes on between doctor, nurse, and patient, the sooner these things get picked up, and the better that they are reversed. I just want to finish up by letting you know that there are other immune therapies in the pipeline, and this is not meant to be a very clear slide, but on the red circle now, you see there's Ipi, which interferes with an interaction between CTLA-4 and its partner molecules, and we discussed that. There's another red circle now around an interaction between 4-1BB, another immune marker on T cells. And BMS has an experimental drug for that as well. There are no trials with it right now, but we're hoping for some in the future. And then down on the lower right-hand side, there is a molecule called PD-1. And if Ipi is the brake on T cells, then PD-1 is the emergency brake. It's like pulling that red cord on a train and making it come to a screeching halt, because PD-1 causes T cells to die. And not inconveniently, many melanoma cells express the partner molecule for PD-1 on their surface as a means of self-defense. And there are now antibodies called MDX1106 and MDX1105 that block PD-1. And this is just my sort of representation of PD-1, the emergency brake. We know now from work done at Yale and Johns Hopkins and Sloan Kettering and many other places, the Harvard hospitals, et cetera, and work that was presented by Julie Bramer at ASCO in 2009, and then Mario Schnall from Yale this year, that there are significant clinical responses to anti-PD-1 in melanoma patients and also in kidney cancer and lung cancer patients. So anti-PD-1 seems to be the next very important immune modulating antibody, and there are ongoing studies of anti-PD-1 alone, and then there's a very small study that is being conducted here at Memorial Sloan Kettering and at Yale of the combination of Ipi with anti-PD-1. So that is the end of my presentation. My conclusions are that we're learning more about how the immune system recognizes melanoma. More new drugs are being developed based upon scientific progress in immunology. Anti-CTLA-4 antibodies benefit some patients with melanoma for long periods of time, and that participation in clinical trials is very important. And I'm going to finish up right there.
Okay, well, thank you, Jedd. That was absolutely wonderful. I understand a lot more. We have a lot of questions from our patients and from our forum, and I think I'll just get started on those. I do want to ask everybody if folks leave early to please take our short survey that we have at the end of the webinar as you leave, and it will help us enormously because we need to know what you think about our program and how to plan our future programs. So it's like 4 or 5 questions. That would be great if you would take that survey. I'm going to start with, is it possible, and I think you mentioned this a little bit, but is it possible to overstimulate the immune system to the point that it turns on the body, causing more harm than good? So
right. So,
yeah.
Yeah, I think that's a great question, and I think what we've seen with some of the side effects from Ipi and other similar drugs, that it is very possible to do that, but that if that begins to happen, if there is good communication between the patient and the treating team, that we can reverse those side effects and restore good health.
I would bring in the caregiver as well,
Yes. Yes.
In
yes,
the communication circle, because sometimes it's very difficult for the patient to communicate everything as well as their caregiver. Okay, is there any likelihood that a trial of anti-PD-1 for those who have already had Ipi might be undertaken soon?
I don't know, but I certainly hope so. There's no lack of interest on the part of the investigators, but we haven't heard about a study for sure going forward yet.
And how about in reverse?
Ipi for people who've had anti-PD-1?
Yes.
I think that people who've had anti-PD-1 are allowed to have or allowed to participate in the expanded access program.
Okay. And how long do you think that will be before the possibility of anti-PD-1 being available to Ipi patients?
I wish I knew. I honestly don't know.
That's what patients really want to know, is when.
Yeah, I know. I don't have those answers.
Yeah. Are there any trials developing for chemotherapy following Ipi? We've been told there are suggestions that Taxol or photomystine following Ipi may enable the immune system to identify or respond to tumor antigens more effectively. Can you please comment on that?
I think that's a really interesting idea. There have been some studies that were conducted about a year or two ago at a few sites combining at the same time Ipi with dacarbazine, with carboplatin and paclitaxel, and just for safety purposes. But you know, the currently still unknown data from the trial of Ipi with dacarbazine versus dacarbazine alone will help us understand whether there's really an advantage to giving Ipi on top of dacarbazine. We certainly hope that there is. Now, the timing of the chemotherapy is important. We don't know for sure whether it's better to give chemotherapy before Ipi, during, you know, at the same time, or after. And I think some of these questions are hopefully going to be addressed once Ipi gets approved.
Well, I think there was also a theory about IL-2, patients taking IL-2 and then going on Ipi, and that they did better after the IL-2. There
are some observations that individual patients have made around that, but there was actually a study of this by Dr. Rosenberg, and I don't think that there was any real advantage, you know, in larger groups of people. That's not to rule out the fact that some people may benefit, you know, from that sort of sequential therapy. But I just don't think we know for sure yet.
Right. I think the study I saw didn't show overwhelming.
Right. That's the one that I remember as well.
Okay. Now I'm not sure what this meant, but how late have you seen brain mets appear in Ipi patients who ultimately were responders? I'm not sure what they mean by late, but
I think I understand a little bit. I personally have had patients who have had stable disease from Ipi for a year or two, develop one brain met, and then never develop any further progression after that.
Okay, and when they do have a brain met, then they get therapy, radiation therapy normally.
Or surgery.
Or surgery. And
Yep.
then could they go back on the Ipi? Or
yes, yes. I mean, I think that if the rest of the disease is stable, then, I mean, I do encourage people to stay on. If there's been sort of we look at sort of the global picture, and if the global picture is of clinical benefit, then I suggest that people stay on, or sometimes get re-induced, you know, to get 4 more doses, which is the way that phase 3 trial worked, that if someone had benefit and then had a recurrence of some kind, whether it be brain or elsewhere, they then were eligible to get 4 more doses after that. So I think, again, it's looking at the whole picture. I mean, if someone has progression in many different places as well as the brain, and really you never really got a flavor that the Ipi did anything, then I think we should move on to something different.
Okay.
But if there was a period of benefit, then I think it's worth trying again.
Good. That sort of answered my next question, but I also was wondering, is it theorized then that Ipi does cross the blood-brain barrier?
So it doesn't matter if Ipi crosses the blood-brain barrier because, again, remember, Ipi doesn't treat the tumor. The immune system treats the tumor. So all we need to get into the brain are T cells. We don't need to necessarily get the drug there.
Okay. The next question is, what do you think of adoptive cell transfer therapy?
I think that adoptive T-cell transfer has really provided some very impressive results in people who can get it. There have been, studies, from the NCI for several years, and now there are smaller programs that are being started at Moffitt and MD Anderson, and also at the Fred Hutchinson, where this is really pure immune therapy, where you're just giving T cells, and the T cells cause the tumors to shrink. There are some challenges which hopefully can be overcome. One is that each patient has to have their own treatment made. There has to be T cells grown from individual tumors or genetically modified out of the blood, and that can sometimes take some time, and sometimes it just can't be done. I mean, I've sent patients to the National Cancer Institute, which has more experience than anywhere else. They take terrific care of people, where it's just simply not possible to get people's T cells to grow. Fortunately, that seems to be less of a problem now over time, but I think we're still learning how to make this treatment available to as many people who want it. But there's no question in my mind that there are some people who benefit from that in a very durable way.
I've only seen very small numbers of patients.
Right.
And
right.
So, and I also, one doctor mentioned to me it's extremely expensive. And
well,
I know we don't think of that, as
no,
I
think as it begins to be considered as something that is done outside, the NIH, then that cost will become more important.
Okay. Well, I can see why now when you explained it in that way.
Yeah.
Yeah. I think we answered this before, but it will be good to go over it. When and if Ipi is approved by the FDA, is it likely to follow the same expanded use protocol that it currently is?
I think the idea is that once the drug is approved, there will be no more need for an expanded use protocol. I don't know if that was the question or not, but
yes.
Okay.
So there wouldn't be any. Would it be widely available in the?
Yes. Oh, I mean, it should be available everywhere in the U.S., right?
But I would guess with the side effects and so on, you should probably stick to a fairly sophisticated cancer center.
There's going to be, and we've been involved in helping to plan this, there's going to be a lot of education for doctors, nurses, patients, and caregivers, associated with the launch, hopefully, of Ipi. So that's certainly on everyone's mind. It's, without a doubt, it's on the FDA's mind as they consider making this widely available. So, again, I think we have the benefit of, several thousand people having been treated, and I think we've seen, pretty much the spectrum of what can happen from the drug, and we've developed very clear and straightforward algorithms for how to treat the side effects that, we are talking to other doctors about. My research nurse speaks to other nurses, so the word is really getting out. There have been terrific educational materials that have been developed. So, I think that the hope is that once the drug gets approved, there'll be a real push for education to make sure that doctors, nurses are very, very equipped to deal with the side effects. It's not that the side effects are so much more difficult to deal with than those accompanying chemotherapy, for that matter. It's just that they're different from the side effects that accompany chemotherapy.
And subtle, would you say?
They can be subtle, and so very modest diarrhea can get bad, and some oncologists may think they know how to take care of diarrhea from chemotherapy like irinotecan, but taking care of ipilimumab diarrhea is very different. So I think that it's just going to be education, because the way that the side effects are treated is really very simple. Most of it can be done in the outpatient setting with pills.
That's great. I have to say that the patients on our forum, they're called the Ipi Gang, and there's quite a few, and they've developed a whole system on side effects and markers, and they're very sophisticated with what's going on.
That's terrific. That's terrific.
The patient actually may be instrumental in, how this works out.
Yes.
I have one final question for you. I think I sent this one to you, and I'm not going to go through the whole case history, but this person has been on Ipi for some time. for 6 years and had new tumors beginning, and his question was how often a booster treatment should be given.
Right. That's a very important question, and the short answer is nobody knows. There are some Ipi studies where people were given one single dose every 3 months as sort of what's called maintenance therapy. There were other studies like the phase 3, the MDX-01020 study, whose data we reviewed, where there was no maintenance therapy. Patients just got the 4 doses, and they didn't get any more unless they had a recurrence. And we know that there was durable benefit seen in those people who didn't have any maintenance therapy. So I don't think anybody knows for sure whether or not it's required after those 4 doses. I think there's a lot that we still have yet to learn, whether if people progress after 4 doses and they haven't developed bad side effects, should we keep giving them Ipi and not stop and move on to something else? You know, what is the right dose? Is it 3 milligrams per kilogram? Is it 10 milligrams per kilogram? If some people don't have side effects at 10, should we go higher? I think there are a lot of important questions that we will hopefully answer after the drug is approved. And these are definitely on the minds of the people who are involved in the Ipi program. Of, you know, what's the role for maintenance therapy? Should we stop after 4 doses for people who don't have a benefit? And should we stop at 10 milligrams per kilogram? So these are very much on everyone's priority list right now.
Okay. Well, that was great. Thank you. And
Sure.
I now know why, you know, your patients speak so highly of you, Jedd. You explained things so well. So thank you so much for taking time out, and to everybody who listened in, thank you for your time tonight, and I think we've all listened a lot. This will be archived on our website shortly. Give us a day, and please take the survey as well.